Welcome everybody, this is Yasser Wasifi again from Learn Dental series. In this episode we will continue our discussion about this long important topic, which is diagnosis and treatment planning in operative dentistry. I would like to declare that I don't receive fees, compensation or royalties from the sales of any of the products shown or discussed in this presentation, and also I would like to stress that this presentation has not been sponsored by any agency, company or organization and is only prepared for educational purposes. This presentation is copyright protected and could not be transmitted by any means unless you have a prior permission from the author. We will continue today for the proper clinical examination to diagnose the patient problem or the patient chief complaint. Already we discussed part 1, which is patient assessment and information gathering, and starting in the clinical examination, including clinical examination of dental caries and the clinical examination of existing restoration. We already finished clinical examination of other tooth defects and adjunctive aids for examining teeth and restoration. In this episode, we will try to finish clinical examination and diagnosis by examining occlusion, examining patient in pain, and examining cracked tooth. Let us start with examining occlusion. Why examining occlusion is important for the treatment planning of restorative cases? Because occlusal records provides an opportunity for a thorough evaluation of interdigitation condition of the teeth and the functional occlusion and any occlusal abnormalities that could be detected and may interfere with proper restorative treatment plan, especially if you have a centric holding area. Centric holding areas in restorative treatment plan is a major determinant of the success of restorative treatment, because centric holding areas is an area of concentrated force in the tooth structure. Not all the occlusal surface of a tooth is in contact with the opposing occlusal surface or opposing occlusal anatomy of the opposing tooth, okay? But certain centric holding areas should be determined before the decision of selection of suitable restorative material and suitable technique. Let us say that we have a direct restorative material which is brittle, then that is transformed or translated into, you need at least 2 millimeters bulk thickness in areas of stress concentration, which is centric holding areas. That's why you should determine the centric holding areas before you start. Also, in other restorative materials or other restorative techniques that requires beveling of enamel, okay, at centric holding areas, there shouldn't be any undermined enamel or any beveled enamel, regardless the excuse or regardless the concept of your preparation. That's why in many of bonded restoration, the concept nowadays is not all undermined enamel should be removed, except that located at a centric holding area, okay, no excuse to leave any undermined enamel, or undermined enamel should be removed. Also, no excuse to cut a bevel, because if you are going to restore the tooth with a direct material, okay, or a brittle, let us say a brittle direct material, it will not withstand the force applied because of the thickness of the material over the bevel. If you are going to restore it with a highly ductile or a high strength properties material like that of cast cold restoration, also it will not fracture, it will not fragmented, but at least your bevel will bend under these centric holding areas, opening the margins and allow solubility of the cement line. Also, you are in need to check the occlusion after you finished your restorative treatment or restorative procedure, okay? Then you are checking your occlusion before starting your treatment to determine any abnormalities and also to determine the centric holding areas. Centric holding areas means that you need a bulk for direct brittle materials. You need to remove all undermined enamel. You shouldn't bevel this margin under center holding areas. After finishing your restoration, okay, you are also in need to recheck occlusion just to make sure that you already achieved your goals, okay, of the restorative treatment, which is the restoration of efficient and comfortable mastication. Those are examples of preoperative examination of occlusion and occlusal centric holding areas, okay, using articulating blue papers, okay, that marks centric holding areas. The question now is, are all of these are centric holding areas that should be considered? And are all of these are considered as a premature contact if I finished my restorative procedures and should be reduced? Let's discuss this, okay, as recommended by many authors, that you have areas of low pressure and areas of high pressure. Areas of low pressure should not be considered as annoying occlusal contact that should be considered during restorative management or after you have finished your restoration, okay? But the areas of high pressure is actually an actual contact which appears very light in color, while the surrounding area, which has no occlusal contact, will be darker in color. How it comes? Okay, I think one of my female students, described it as it's a donut's shape. It's like the donuts, which is hollow in the center and concentrated as a periphery. Okay, how it comes? Let us discuss it. When we have an area of low pressure, okay, a light occlusal mark, which is faint and nearly the periphery of this circle is having the same depth or much more darker than the center, but still there is a homogeneity in color, indicating that the articulating paper is squeezed between the two cusps or the two occlusal contacts, okay, with a very low pressure that homogeneously distributes the color of the articulating paper. While the high pressure area, okay, is denoting a dark occlusal mark with a light mark in the center. This light mark in the center means that there is an excessive force that drives away your ink or blue ink to the periphery of the contact area, and the white ring, the white circle in the center, this is the high pressure area that should be relieved, not the dark part surrounding it, because of squeezing of the color and the excessive pressure that drives your ink to the periphery of the high pressure area. Okay, then as you could note the red arrow, this white area, okay, or this light color dot, this is the high pressure area that should be relieved. And as long as the color is lighter, this means that the pressure is higher. Okay, then what is the technique to examine the occlusion? Simple technique is using articulating paper. Okay, it could be used to examine centric holding areas before preparation and premature occlusal contacts after restoration. I'm one of the operators who preferred always to check centric holding areas, and I didn't like to wash the marks from the tooth during cutting or preparing the cavity. And even before restoring the tooth, I re-examined the margins for presence of centric holding areas at the margins. Okay, if you could capture a photograph with intraoral camera or with any camera, even with your mobile camera, just before starting your preparation, okay, just to remind you by a way or another where is the centric holding areas, as actually it will be washed with your coolant spray. Okay, after that, articulating paper is used to determine premature occlusal contacts after restoration. I also prefer to compare photographs of pre and post-operative to compare the degree of pressure. It's a very simple way just to imagine and to give a conclusion about the occlusal condition of your patient and the condition of your occlusion. Also, in much more complicated cases, we have to take an impression to get a mounted study cast for upper and lower. Also, it is preferable in much more complicated treatments that involves a quadrant or involves much more than one individual tooth. Okay, and also in certain extensive carious lesions or extensive restoration for individual tooth, I prefer to have upper and lower full arch impression and to get mounted study casts, okay, to be mounted even if it is a simple hinge articulator, but I prefer to use semi-adjustable one to examine your examination, because mounted study cuts provide us with an idea about the plane of occlusion, tilted or extruded teeth, cross bites, plunger cusps, especially in cases of extensively damaged teeth, that allows a space for tilted or mesial drifted neighboring or over erupted opposing, either it is upper or lower, that provides plunger cusp action. Okay, also ear facets could be examined from all dimensions, buccal, lingual, mesial, and distal, including also defective restoration. The coronal contours, proximal contact location, and the embrasure and spaces between teeth are also could be checked by mounted casts. Waxing up and mock-ups for the purpose of clarifying the proposed treatment plan and having a complete overview from all aspects, buccal, lingual, mesial, distal, okay, could be checked by waxing up and mock-ups on mounted cusp. Mounted cusp combined with radiographic findings, including panoramic views, bite wing views, and periapical views, will allow you to develop a treatment plan without the presence of the patient. Thus, if you have your mounted cast, your panoramic views, and your records about the case, about other clinical examination, then you have all the problem, and you have could get a clear view about your problem, that you could design clearly your treatment plan. Okay, then coming on to the patient to discuss it with him. That's why your mounted cast study casts, especially if you design a waxing up or mock-ups for the proposed treatment plan, especially in cases for correcting aesthetics and smile design, it is better to get your mounted study casts with your OBGs, and you have already written your design or treatment plan and discuss this for the patient. It is an amazing excellent tool for patient education and communication with your patients. This is a study cast mounted with waxing ups and mock-ups. Nowadays, the digital era and introducing digital dentistry in our clinical practice, enabling us to make this waxing up in a digital form, like that for smile design, digital smile design. And instead of making it on mounting cast, already you study the mounted casts and transfer its image by a special scanner to your system, to your software, and you could design this waxing up or mock-ups digitally and illustrate it to your patient and discuss it with your patient, not only with a wax of different color, but it could be in a real condition or simulating the real condition in your screen in front of your patient, and you could move it from all aspects. This is differs according to the system you are using in digital smile design or in any complicated dental restorative management. But all of these, either articulating paper or mounted study casts, or these study casts or mounting of it, are transmitted into a digital display system, but it doesn't quantify the degree of pressure your masticatory muscles exert in your occlusal surfaces, and to how much you could score this pressure or this force. That's why the introduction of digital scans, which included a sensitive plate, okay, that allows the patient to bite on it and transfers this to a special software to analyze quantitatively the degree of pressure and score it in a numbers and score it in a color coding, which one is high pressure that should be relieved, which one is acceptable, okay, and how to measure the masticatory force and how it affects your occlusion and force applied to different restorative management and different restorative treatments. Okay, that's why digital scan is introduced that analyze the patient occlusion, evaluating the occlusal forces, okay, just by simply having the patient bite down on ultra thin sensor. Okay, too many systems are developed in based on this idea. Today we will discuss one of the most recent. It is not the ultimate recent one, but it is one of the most recent, and you could easily understand the idea from discussing it, which is occlusense. Occlusense is depends on a sensitive plate, okay, which also is ink saturated that allows marking of the high pressure areas with red marks on occlusal tables of all teeth, okay, just to guide you where is the areas that should be relieved, okay, and then transmitted by Wi-Fi, okay, wireless connection to iPad application or to computer application or software, just to record, evaluate, organize, compare, and export the exposure, the occlusal readings. Okay, it's very simple. This is the plate which recorded masticatory forces in 256 pressure levels. Then it is scored from 0 up to 256 pressure levels. It is similar exactly to the strips for glucometers, which is sensitive to glucose in blood, okay, and give you the number. This is sensitive to pressure from 0 to 256. The thin flexible plate is disposable, used once for every patient, okay, and you could use it just as simple as letting the patient biting on it in static and dynamic occlusion. The records are then transmitted to the application via Wi-Fi, okay, and you have clinically a red color coating marks on the occlusal contacts, okay. You could, according to the system analysis or the software or the application analysis, remove the high spots, okay, and recheck occlusion again. Let us review this clip. This is, as you see, the plate which is applied to your device. Okay, it's an electronic disposable one like that of glucometers. Okay, then let the patient bite on it. For the recommended time, the analysis of force is transmitted to your application, giving you color indicators, and at the same time, the same red colors in your application is marked by red ink intraorally to guide you where you should relieve the overpressure, and indicating to you the degree, the quantity of high pressure, okay, and give you a priority where to start with, okay. Then after you remove it, recheck occlusion again for the recommended time, okay, and compare between before and after. Here we have still a little bit high pressure occlusion, okay, that needs to be re-relieved again. You could compare and subtract between pre-operative and operative. This is the device which have a charger, okay, it's a wireless one and connected to the app in your iPad or in your CPU by wireless connection, okay, through Wi-Fi. Then coming, this is about examining occlusion, then coming how to examine patient in pain. This is a very simple and a very tricky type of examination, of clinical examination, because treating patient in pain is a challenge that depends mainly on the operator diagnostic skill. If you didn't find the offending tooth, please don't start any treatment because you will complicate the condition. Just wait and see, or refer the patient to another operator, or have a consultation with a higher skill operator or consultant. Skillful operator should determine and diagnose the cause of discomfort and then provide a relief. Okay, that's why don't be in hurry. Please take your time to ask the patient and to get the history. The problem could be identified and treated by careful piecing together subjective information from the patient through the history and objective information from the clinical examination, along with appropriate test. Okay, this could be run as the following plan. Number one, regardless the patient is new or regardless the patient is a common regular one, and you have his full record at this time when he is in a pain, consider him as a new one and take a new medical history, okay, in full details, or at least review the medical history recorded before with your patient. There may be sometimes a newly developed condition, okay, in this few times that affects the pain threshold of your patient. That's why he may exaggerate the sense or exaggerate how he could express this pain, okay, and may express it in acute phase while it is not that true, okay. Then ask the patient to describe the problem in detail, okay, including the onset and duration of pain, stimuli causing the pain, spontaneity of the pain, okay, intensity of the pain, factors that relieve the pain. During this discussion, the dentist begins to formulate, okay, an idea about the potential cause of the pain, and that means, okay, and the means to verifying it, okay. That's why you should listen to him perfectly. Don't be in hurry. Let him complete what he is talking about and ask him for detail. That's why care should be taken not to focus too quickly. Let him express. Okay, instead, all possible sources of pain must be considered. Either it may be a systemic pain, bulbar pain, periodontal pain, restorative, degenerated, or maybe neoplastic pain. That's why it is important to listen carefully and analyze carefully and ask more questions to your patient to get all the full details about this pain and about his feeling, okay, of this pain, and about also his pain perception threshold. Then after that, coming for subjective symptoms by assessing or clinically examining the patient and developing a preliminary diagnosis. A thorough clinical examination with the use of all adjunctive aids available to diagnose the condition, especially radiographic examination, is done. In addition to periodontal evaluation with periodontal probing that can help to rule out if there is a periodontal abscess especially, and the integrity of existing restoration is evaluated, okay, as described before to confirm your diagnosis. Most probably patient in pain, it may be a case of reversible or irreversible bulbitis. Okay, then how to differentiate between reversible and irreversible bulbar pain, especially there is a very limited margin between them. For reversible bulbitis, characteristics of pain, it is a short sharp one, while for irreversible bulbitis it tends to be slightly dull and throbbing pain. Okay, but the patient may experience or express that there is bouts of sharp pains or episodes of sharp pain in between. Okay, but it is mainly dull or throbbing pain. Okay, for reversible bulbitis, it is stimulated by hot, cold, or sweet stimuli. For irreversible bulbitis, onset is usually unprovoked or exacerbated by hot, cold, or sweet stimuli. Maybe a little bit continuous. It doesn't need a stimuli to be provoked. A few seconds after stimuli, in case of reversible bulbitis, the pain disappeared when your stimulus is removed, while for irreversible bulbitis, several minutes to several our persistence of pain is recorded after removal of stimuli. Bulb sensibility test may elicit an exaggerated response in reversible bulbitis, okay, and for irreversible bulbitis also may show exaggerated response or maybe negative response at all in advanced cases, okay. In reversible bulbitis, the tooth is not tender to percussion, while in irreversible bulbitis, it started to be tender to percussion because the condition started to extend outside the root canal to periapical area. But if you couldn't determine exactly is it reversible or irreversible because the management is absolutely different, okay, take the positive side, which is dealing with it as reversible unless the pain continues, okay. If there is a very thin border or margin that you could misdiagnose between them, then consider it as reversible unless the patient already expresses what is exactly denote it is irreversible bulbitis, okay. Then coming exposed sensitive dentine. Exposed sensitive dentine shows poorly localized, short, sharp sensitivity to hot, cold, or sometimes sweet stimuli caused by exposed root, dentine surface, or gingival recession or root caries. Then clinically, you may note that the patient have a gingival recession or exposed root or cervical caries, root caries, okay. The pain can be elicited by air drying of the exposed surface using the triple way air water spray, okay. The bulb shows positive sensibility. Sometimes it may be hyper responsive, okay, a little bit, okay, and the tooth is not tender to percussion. To reduce the sensitivity of this case, the exposed dentinal tubules may be blocked using either bonding agent in a thin layer, okay, or a thin layer of resin composite such as flowable composite to block it. Sometimes there was in a less severe cases, you could use dentinal tubules blocker like potassium nitrate, potassium chloride compounds that may be present in certain toothpastes, okay, and apply it for few minutes just to reduce tubule conduction and pain transmission. Finally, examination of cracked tooth. What is meant by crack? Crack is defined as incomplete fracture that not directly involving a vital bulb, because if it is involving a vital bulb, then it will be diagnosed as severe pain due to bulb exposure, and you could note exactly the fracture and the bulb exposure, traumatic or mechanical bulb exposure. The complaint in case of crack, when it is involving enamel only, okay, the patient will not report any pain similar to superficial crack in a porcelain teacup, and may be in certain cases discovered accidentally, okay. When you are examining the patient for another condition, you may discover this crack in enamel only, okay. But cracks that involve enamel and dentine, which may or may not include the bulb, okay, not frankly including the bulb causing exposure, but it means that it is near to that the bulb can cause poorly localized pain periodically from time to time. Sometimes there is a sharp pain on biting, okay, or applying thermal stimuli, okay, and this is an indicative for the presence of crack. That's why you should consider it while you are examining the patient clinically. Let us go for clinical examination. Clinical examination, mainly with transillumination or dye, can be used to detect cracks in presence, or by the aid of magnification, it is easier to diagnose it, okay. And it could be diagnosed by careful analysis of pain on biting, okay. The problem for dye or transillumination, okay, or in general, clinical examination of crack did not correlate it in most of cases to the cause of this crack, Okay, that's why you should refer to the history, you should refer to examine the occlusion, to examine the full mouth, to localize and point out the exact cause of this crack. Most probably, it is due to it is a subsequence of extensive damage due to either caries, the original case, or due to overcutting of your prepared cavity. When you are diagnosing it by determining the pain on biting, just use any object just to concentrate the force over this tooth to determine the presence or absence of pain that indicates that you have a crack involving enamel and dentine and may affect the pulp. Okay, presence of pain on biting that is relieved by opening. Okay, plus to the dye that could penetrate to this crack are indicative for the presence of this crack. You could use cotton rolls, wood sticks, either wooden tongue depressors. Okay, you could use the rubber suction tip, or you could use a proprietary kit, which is the tooth sloth that could diagnose where is the crack exactly, to which cusp it is related. Okay, pain on a specific cusp or at a specific angle of pressure, okay, could indicate the presence of the crack. Okay, and this helps to ascertain where and how deep the crack might be, and thus what treatment is required. Radiograph is also helpful, but radiograph is not definite because it's a two-dimensional representation of three-dimensional problem, and most of the cracks could escape from appearing in radiograph unless already the displacement take place to be clear in your radiograph. This is the trans-illumination used for diagnosing the presence of tooth cracks. This is the dye penetration, okay, applying the dye, then washing the tooth and drying it. All the dye is washed except that in the crack, okay, by the help also of magnifying loops or microscope. You could determine the extent of your crack. This is the tooth loss that force the occlusal force or the occlusal pressure to certain cusp to determine at which place and to what extent the crack is present. The management of crack tooth differs according to the pulp vitality and pulp involvement, the extent of crack, and the mobility of the cracked part of the tooth. It ranges from just removal of the cracked part and involving it or restoring it by involving this missing part in your restoration, either by direct bonded restoration or indirect restoration, either metallic or non-metallic, okay, or maybe a root canal treatment due to pulpal involvement by a way or another. But the problem is always in deeply extended cracks, okay, deeply extended cracks that are not violating your biological width. It should be managed like that of deep carious lesion, and just according to the degree of damage, select which type of restoration you are in need, either direct or indirect, and where is the area. Is it lingual or buccal? The lingual mostly favor to be indirectly restored just to adjust contact and contours, okay, properly. But for crack lines that extended deep and violate the biological width and the periodontal consultation, prefer not to go for surgical crown lengthening because it will affect your anti-slow and the tooth will undergo mobility and loss a lot of alveolar support. Then it will be an surgical extraction. This will be the final treatment. Finally, those are my textbooks. Okay, if you would like to get further information about this topic, and please feel free to ask, as your questions are welcome 24/7. Just ask by commenting to this video and I will reply to you as soon as possible, or just send me an email and I will reply to you as soon as possible. Finally, don't forget to like this video, subscribe to my channel and activate the notification to get all the updates, and thank you for assigning this time to listen to me. ياسر الوصيفي.